turn now to the perioperative setting for the last few minutes of our discussion, which has been really riveting. It was a great ASCO, even though it was virtual. So many great papers were presented. So I think it's given us an opportunity to have a very rich discussion today. So Aditya, there was a study looking at metronomic capecitabine maintenance after standard treatment in early stage triple negative breast cancer. Patients got a full year of continuous capecitabine. It wasn't like CreateX where patients were treated only if they had residual disease after standard neoadjuvant therapy. And the results were kind of compelling and interesting. I'm wondering what your take is on this, and if you could go over the design and results a little bit.
Yeah, absolutely. This was a randomized phase 3 trial conducted in China. In this trial, patients with operable triple negative breast cancer, after they completed their local and systemic treatment, were randomized to metronomic capecitabine at 650 milligrams per meter squared twice daily for 1 year versus observation. And the primary endpoint of the study was disease-free survival. 434 patients were randomized to capecitabine versus observation. And the study essentially demonstrated an improvement in 5-year disease-free survival with capecitabine as compared to observation. The 5-year disease-free survival rate was 83% with capecitabine as compared to 73% in the control group. The overall 5-year survival was not different between the two groups. You might need more follow-up to look at overall survival. In terms of side effects, the common side effects that are observed with capecitabine, including hand-foot syndrome, leukopenia, GI discomfort, was seen in the study. 46% of patients had hand-foot syndrome with capecitabine. In this study, 91% of patients were able to complete 1 year of capecitabine therapy. So the overall message from the study was maintenance therapy with metronomic capecitabine is associated with improved disease-free survival. Does this impact clinical practice? I would actually like to see more data, especially with the compliance of capecitabine. I'm a bit surprised to see such high compliance of capecitabine at this dose for 1 year. So in a more real-world setting or maybe a different patient population, it would be important to look at this question and to really see if capecitabine is associated with improvement in progression-free survival. The other thing to consider is that in this study, capecitabine was used in a format that's different from CreateX, and more for stage 2 and stage 3 triple negative breast cancer, we are using neoadjuvant therapy, and in patients who have residual disease, they receive capecitabine. So I'm not really sure that these data necessarily change that practice.
Yeah, you make up some really good points, and the different pharmacogenomics for different patient populations, I think is something that needs to be explored. So Sarah, how are you seeing these data? Are there going to be patients who you treated in the adjuvant setting and didn't have the benefit of their response to neoadjuvant therapy, where you might apply these data, or are you too waiting for more data regarding tolerability and benefit?
I mean, I think just practically speaking, we are usually giving preoperative therapy to the vast majority of our triple negative patients. So, really, if they have a tumor over 1.5 centimeters, they're getting preoperative chemotherapy in our practices. And so it has become quite standard, if there is residual disease after pre-op treatment, to administer 6 months of capecitabine as per CreateX. I will say that I don't really use the dose that was used in CreateX, that I do tend to go down to more 2,000 milligrams per meter squared. And, even then towards the end, people can have a tough time. So, it's hard for me to see very many patients where this would become a practical option, just because we're not really giving much adjuvant therapy. And we do have the ability to assess response to pre-op treatment. But I think there are going to be a lot of questions that come up in the next couple of years if we also start moving towards immunotherapies and what the role will be in the post-pre-op setting for these agents. So, there are other agents that are getting studied in the post-pre-op space as well, drugs like sacituzumab. And so I think there's going to be an evolution here. But for now, I would follow more CREATE-X standards and use 6 months of capecitabine.
Great. So we've had a very collegial, cordial discussion, and now I'm going to bring up something that pits East against West, and the deck is stacked against me here because you three are from the East Coast and I'm from the West Coast. But TRAIN2 data, looking at the outcomes of patients treated for HER2-positive breast cancer in the neoadjuvant setting with an anthracycline-based therapy or a non-anthracycline-based therapy. All patients received trastuzumab, pertuzumab. A few years ago, showed no difference in pathologic complete response rate between anthracycline or non. And they presented the 3-year event-free survival. So I want comments from all of you on this particular paper, and I'll try not to color it with my West Coast take, which you probably already can tell. Aditya, can you tell us what the results showed in terms of EFS, and are there patients who still need anthracyclines?
Yeah, absolutely. So this was a clinical trial, phase 3 clinical trial, looking at patients with stage 2, stage 3 HER2-positive breast cancer who were randomized to receive a neoadjuvant therapy with an anthracycline backbone or without an anthracycline backbone. So patients who received anthracycline backbone received FEC, a regimen that's used in Europe, followed by 6 cycles of paclitaxel and carboplatin. And the other group received 9 cycles of paclitaxel and carboplatin. All patients received dual HER2 blockade with trastuzumab plus pertuzumab. After surgery, patients received 1 year of trastuzumab and endocrine therapy for hormone receptor positive, HER2-positive disease. The primary endpoint was PCR. So in the study, after follow-up of close to 5 years, the authors reported no difference in the 3-year event-free survival. It was excellent for both arms, 92.7% for the anthracycline arm and 93.6% for the non-anthracycline arm. There was no difference in overall survival as well. Subset analysis based on hormone receptor status and nodal status also showed no difference. There was a difference in toxicity. Patients who received anthracyclines were much more likely to have decline in EF. So I think the data are quite compelling and essentially highlight the role of a non-anthracycline-based regimen in the neoadjuvant setting. Would it change my practice? In the past, I would either use ACTHP or TCHP for a patient with stage 2, stage 3 HER2-positive disease. But now more and more, we are using THP in the neoadjuvant setting, and in patients who have a PCR, they receive anti-HER2 therapy with trastuzumab. So we are already de-escalating the neoadjuvant regimen, and I think these data just support the de-escalation.
Yeah, speaking of de-escalation, Sarah, the data I think were really interesting because this is the first study that actually looked at the platinum plus the taxane plus the anthracycline. So patients in the anthracycline arm received 5 chemotherapy drugs plus 2 HER2 targeted therapies. Talk about escalation of therapy versus a TCHP type of regimen. What is your take? What are you doing in practice? And being the mother of APT, I'm really interested in your thoughts from a de-escalation approach.
Well, you know, coming from the East Coast and being raised on the East Coast, I did often use anthracycline-based therapy, particularly during my training and then, you know, early into practicing. And even when BCRG-006 was presented, I was still a little reluctant to sort of get rid of anthracyclines. You know, those data were compelling, but you know, the study BCRG-006 hadn't been powered to compare the two arms, and it was only one trial with long-term outcomes. And so I still was a little reluctant. But I will say I have changed over the last few years. I think the TRAIN2 findings certainly support that. You know, I think it's telling us that we do just as well with non-anthracycline-based therapy with long-term follow-up, and importantly, even in the highest risk patients. So they even subdivided out by degree of nodal involvement. You can still see that there is no benefit favoring the anthracycline arm. And this was also true in BCIRG-006, even in the 4 or more positive node patients, no benefit to anthracycline over taxane-based therapy. So to me, this is sort of an end of an era for anthracyclines in the HER2 positive space. You know, I think we've also gotten better with our HER2 biologic therapies. So we're now able to sort of pull back on chemo backbone as we escalate HER2 biologics that are more and more effective. And I think Aditya pointed this out, that we're even going further. You know, in the Compass trial, they are trying to say, can we get away with even less chemotherapy now that we can use dual HER2-directed therapy? So can we just do single agent taxane with trastuzumab and pertuzumab, and then use response after preoperative therapy to confirm they did okay with THP, and if they got a PCR, then just continue HP out back. And so obviously we need those data to confirm that. You know, DFS will be just as good as we've seen previously with things like TCHP, but you know, as you note, there's a big movement towards de-escalating as we are getting better with our HER2-directed biologic therapies.
Yeah, I would mention there was a phase 2 trial that was presented as a poster at ASCO. It didn't get much attention, but called the Neocart trial. I believe it was an Asian study looking at TCH times 6 versus EC times 4, followed by TH times 4. And the path CR rate again was higher actually with the TCH regimen. Again, epirubicin based, not doxorubicin based. So the data is beginning to mount in that direction. Claudine, what about you? How do you take these data? You know, I thought it was interesting in TRAIN2, they did the subset of N1 disease and then N2 disease, and you still don't see a benefit with N2 disease. So a lot of my colleagues will say, if a patient has 3 or 4 lymph nodes involved or greater, I'm going to do ACTH. What is your take on this sort of subset grouping and whether or not you escalate therapy?
So I have to say I agree with Sarah, and I think you guys on the West Coast had it right before we did on this one. I actually have started to shift in the past 5 years or so, and I'm using less and less anthracyclines, unless I'm participating in a trial that has them. But in standard clinical practice, I'm primarily using TCHP in my higher risk patients. And I think, as others have indicated, thinking about whether there are groups of patients where you could go to single agent paclitaxel and use response to guide therapy. And in some ways, that was even pushed harder by COVID, as we've been trying to minimize toxicity, minimize visits. A variety of things that has come into play as well. But my standard, I was very happy to see this result as well. It made me feel even better about the decisions that I have been making over the past couple of years, because I think I've grappled with my patients who have N2 disease. Is it really the right thing to avoid using anthracyclines? But I think with the data from the Caitlin trial about using TDM1 in our patients who don't achieve a pass CR, it feels a little bit safer, or it felt safer, and now it feels increasingly safe from Catherine data, to really say that we can just use TCHP, then use the response to therapy. But again, I think it underlies something that we talked about before, the incredible importance of using neoadjuvant therapy, so we can have that in vivo individualized assessment of benefit from the neoadjuvant therapy, so we can make the decision about what to do on the post-op setting based on Catherine for our HER2 positives, and capecitabine data based on the CREATE-X and other trials.
Yeah, excellent. It's certainly an exciting time for us. I'd like to round up by asking each of you for either a final comment or point you felt you weren't able to make because I just kept cutting you off. or if you don't have a point you wanted to circle back to and make, maybe a highlight that you think was the highlight of ASCO 2020. So first I'm going to go to Claudine.
So there was one point that I just want to make about one of the trials. So in Nadine Tung's trial, the TBCRC048, I think the other important finding was that there was no benefit for olaparib in patients who had ATM and CHEK2 mutations. And I think I step back from this, and maybe because of years of watching this and trying to take messages from trials. And one of the things that I think has been a consistent message is the importance of clinical trials, so we can really be as informed as possible about things, because we shouldn't extrapolate because it worked in PALB2, it'll work elsewhere. I think my take-home message maybe from ASCO, which was a really data-rich ASCO, it was a lot less personal, but there was a lot to take home from it, is that I think we're getting better and better at individualizing and personalizing and identifying groups that benefit from things, both where we can think of a specific therapy for a group of patients, or think about where we can pull back on things as well. So there were a lot of other presentations. There was follow-up from MINDAC. There were some other interesting presentations in the preoperative setting as well. But I think we've gone over the major ones here.
Excellent. Sarah, any final thoughts?
I would agree. I think the theme really is individualization of care, that, you know, we can find these biomarkers like PD-L1 and be able to use checkpoint. We now see germline PALB2, somatic BRCA, PIK3CA mutations. We heard a lot actually at ASCO also about ESR1 mutations. And so, you know, I think this is the direction we're really moving in, is how can we really personalized therapy, hopefully to try and de-escalate the toxicities, but also improve the efficacy. And I think we really are starting to make headway there, which is really exciting to see.
Excellent. And Aditya?
I agree with what's been said. To me, ASCO just again emphasized the importance of clinical trials. There were a couple of studies that were presented that changed or challenged the paradigm. The Parsifal, we all thought that fulvestrant would be better, but the results were opposite. Even the plenary session by Dr. Seema Khan, there was a lot of controversy. People felt that we just need to do surgery, and it just challenged that paradigm. Even believe there was some preclinical and biomarker data to suggest cross-resistance between CDK4/6 and PI3 kinase inhibitor mediated by PTEN loss, but believe clearly showed that PI3 kinase inhibitors have activity post CDK4/6. So to me, it just emphasized the importance of doing prospective clinical trials that can guide clinical practice.
Absolutely. We must remain evidence-based to give the best personalized therapy and give the greatest chance of good outcomes. This has been a fascinating discussion. You guys are awesome. Big thanks to the three of you, Drs. Aditya Bardia, Claudine Isaacs, and Sarah Tolaney, for this very lively discussion and friendly. And thank you again to our viewing audience. We hope you enjoyed this OncLive presentation of Breast Cancer Talk, and we hope to see you next time.